Good evening, everyone. Thank you for joining us for tonight's webinar, Living with Pancreatic Cancer, organized by the Florida Society of Clinical Oncology, or FLASCO. FLASCO is a member-supported state society that focuses on supporting and representing the oncology workforce of Florida. Together, FLASCO is the voice of oncology in Florida. Many of the individuals participating in this webinar are FLASCO members, and we're grateful for their support. My name is Dr. Jason Starr. I'm an oncologist at Mayo Clinic in Jacksonville, Florida. I will serve as both the moderator and presenter for the webinar. During tonight's webinar, the panelists and I will discuss the basics behind pancreatic cancer, basics of pancreatic cancer, treatment options, resources for patients and caregivers, patient advocacy, and more. We'd like to thank Ipsen and the Pancreatic Cancer Action Network, which I affectionately refer to as PanCan, for sponsoring this webinar and making it possible for us to share this important information. Before we begin the presentations, I'd like to let everyone know that this webinar is being recorded so that those who are unable to attend can view it at a later time. Also, your lines will be muted for the duration of the webinar. Toward the end of the meeting, we will host a question and answer session, and we encourage you to submit questions throughout the webinar via the on-screen questions box on your GoToWebinar panel. We will discuss as many questions as time allows. Handouts mentioned in the webinar can be found in the handouts drop-down box on your GoToWebinar panel. So make sure to download them before the end of the program. It's an honor for me to introduce our accomplished group of panelists for this evening's webinar, and I'm very thankful to share the stage with them. I will briefly introduce them now, but please read their impressive bios in the webinar agenda available for download in the handouts box on your GoToWebinar panel, as mentioned. Our first panelist, Dr. Ahmed Zakari, is a hematologist oncologist with Advent Health in Orlando. He's also the chairman of Advent Health's Orlando Division of Hematology Oncology and directs the hospital's gastrointestinal oncology program. Our next panelist is Dr. Peter Hussein, which is he's returning for his consecutive year along with myself, and he is a specialist in medical oncology at Sylvester Comprehensive Cancer Center, where his focus is on pancreatic cancer. Dr. Hussein is also the co-director of the Gastrointestinal Cancers Site Disease Group at the University of Miami. Also joining our panel is Raymond Penn with the Pancreatic Cancer Action Network, also a returning member to this webinar. He works towards the organization's mission to improve the lives of everyone impacted by pancreatic cancer by advancing scientific research, building community, sharing knowledge, and advocating for patients. After the Q&A, we will hear from our final panelist, Dr. Michael Diaz, who is the Assistant Managing Physician for Florida Cancer Specialists and Research Institute and the Director of Patient Advocacy for FLASCO. He indeed is a fierce patient advocate. Thank you, panelists, for joining us to share your insight on the different aspects of living with pancreatic cancer. So we are going to start off the presentations with an overview of pancreatic cancer, and that cues myself. So I'm going to see here if these slides are up. So I am going to give an overview of pancreatic cancer, and really what I wanted to focus on is what questions you could come in and be prepared to discuss with your oncologist about the disease. Next slide, please. Well, I don't see the slides coming up here. All right. I'm going to wait here just to see if I can get the slides loaded here. I apologize. Technical difficulties. Okay, well, okay. So it says it looks like I'm going to be seeing him in a minute. So Like I said, when you go see your oncologist, I want you to be armed with questions so that you know what to ask and to be informed. I think being your own best advocate. Obviously, there's advocacy groups. We're going to discuss, PanCan. Uh, and those are very helpful. But being your own advocate is something that I would really, really emphasize. Don't be afraid to ask questions. You should expect that your oncologist, your care team, is there to, spend the time with you, answer the questions that that you have. So the questions that I would suggest, as a basic framework for asking your oncologist is, what is the stage of my cancer? Am I a surgical candidate? What are my treatment options in general? And should I have genetic testing done? As well as our clinical trials an option. Next slide, please. So in terms of the stages of pancreatic cancer, the stage is not as relevant as whether or not the disease is resectable or potentially resectable. An exception to this would be whether or not there is obvious lymph node involvement, which would make the disease stage 3, or if the disease has spread outside of the region of the pancreas. So in the absence of spreading outside of the pancreas, or at least the local lymph nodes, we divide the cancer into 3 different categories: resectable, borderline resectable, and locally advanced unresectable, although there is a portion of percentage of patients that can potentially be converted to resectable in that setting. Next slide, please. So the resectability depends on the anatomic structures involved. So as you can see here, the pancreas is embedded around a lot of different structures. You have the small bowel here, the duodenum. You have something called the superior mesenteric artery coming out the bottom there. You have above that, there's something called the celiac trunk. You have the splenic artery, which is a part of the celiac trunk. So there is a lot of different blood vessels involved in this region. It's a very delicate real estate. So it's very important that you have a team, which is what we call a multidisciplinary team, which involves a surgeon, which involves a medical oncologist, which involves a radiation oncologist, and typically, among others, typically they would meet at a tumor board and discuss your case and then come up with an individualized plan for your care. You do want to be at a center where they have a lot of experience and expertise in treating pancreatic cancer. The data shows that the better outcomes are at facilities that do higher amounts of these surgeries and treat more of these patients. Next slide, please. So resectability can be in the eye of the beholder. So there's a lot of variations that are considered, and there's a lot of different classification systems that determine resectability. What's critical is that you have a dedicated CT pancreas protocol with dual phase contrast. So you want arterial and venous phase to evaluate those blood vessels. And the slices of the CT are thinner when you do a pancreas protocol CT as opposed to a regular CT. At Mayo, we do more MRIs, but this is not the standard, I will admit, but we preferentially do MRIs. So determining if you are a candidate for surgery can vary from surgeon. So it's always a good idea to get a second opinion if you've been told that your tumor is not resectable. And sometimes, even if you're told that it is resectable, if you want just, if it's very fair to ask the surgeon how many Whipples they do a year, which is a surgery that they do for pancreatic cancer. That's a fair question to ask the surgeon so that you can determine if that's someone that you're going to feel comfortable with. It's your life, it's your body. Next slide, please. So treatment options for advanced disease. So if the disease is not resectable or if the disease has spread outside of the pancreas, the mainstay of treatment is chemotherapy. And Dr. Hussein and Dr. Zakari will talk a little bit about those therapies. For localized disease, we have shifted our approach from doing chemotherapy after surgery, which would typically be referred to as adjuvant after surgery, to before surgery, which is called neoadjuvant. The reason for this is many, and one is we know that chemotherapy improves outcomes in this disease. We also know that after surgery, a good percentage of patients don't get the chemotherapy that they need. When you give it before surgery, you ensure that the patient gets the chemotherapy that they need. Radiation is controversial. We're still waiting on some data in the adjuvant setting after surgery. But before surgery, we have traditionally incorporated radiation, although there was some recent data to make this more controversial. But it's taken on a case-by-case basis when the surgeon and the medical team thinks that the margin may be close, meaning when they try to take out the cancer, if they think that they may leave something behind, then radiation sometimes will ensure that the margins are negative. Next slide, please. So genetic testing. All patients with pancreatic cancer should have genetic testing. And that is a true statement that's in the guidelines. And this is to determine if you could have inherited genes from your mom or dad that contributed to the development of cancer. This is said to be inherited genes are said to account for, somewhere around 3% or so of pancreatic cancer. So it's a lower number, but it's still a number that is high enough to justify doing the testing. Now, on the flip side, all patients with locally advanced, where you can't resect the disease, or metastatic, where the disease has spread, should have testing of their genes. So they're ones that they inherited from mom and dad, and the genes in the cancer. Now, if you inherited a gene from mom and dad, such as a BRCA gene, we see most commonly, or actually an ATM mutation, which is another gene, is actually the most common one that we find. Then you would also likely, or almost certainly, see that in the genes of the cancer cells. But sometimes we find mutations within the cancer cells that you didn't inherit from mom and dad. These are mutations that were acquired that may have led to the development of cancer in the first place. Cancer is a disease of the genes, in essence. So you want to test the genes you inherited and the genes within the cancer cell to determine if there is something that we can target. Now, Dr. Hussein in his presentation will talk a little bit more about that. There are some targeted treatments that we can use that can really change the prognosis of this disease. Next slide, please. So clinical trials, I must advocate for clinical trials. It is the only way that we can move the field forward, that we can come up with better treatments, that we could, eventually defeat this disease, turn it into a chronic disease, and do better for you. So there's clinical trials. I could give a whole, hour discussion on this, but there's different phases of clinical trials. Your oncologist, your care provider should discuss with you what phase the trial's in, what is some of the data that we've seen with the drug or the drugs, what the potential side effects are. Sometimes with a phase 1 trial, we don't know so much because it may be the first in human kind of testing, if you will. You want to know if there's a placebo involved, all these things. But again, the only way we move the needle is clinical trials, plain and simple. Next slide, please. So again, I want to reiterate advocating for yourself. Ask questions, seek answers. That's why we're here. We are here to answer questions and give you our expertise and all the years of training we want to share with you. Join PanCan. I will definitely do a plug for PanCan. They have a clinical trial navigator to kind of recircle back to the clinical trials. They offer all their services for free. They have webinars. I get a lot of questions on nutrition. They have a lot of information on that. So I can't emphasize that enough. And consider being active on social media. I do have patients who follow me on my Twitter. I love interacting with patients and advocacy groups on Twitter. It's the essence of why we do what we do. So to be able to interact on that level, share information, and again, you're advocating for yourself when you're doing that. Next slide, please. So some parting words from my perspective is that there is hope. We are making progress. And it's been slow, but it's progress nonetheless. And I want to thank each and every one of you for attending tonight. This is a form of advocating for yourself. And so I really admire your courage and your tenacity and the optimism that you instill in all of us that care for you, that we can do better. And so thank you all so much for your attention. And now I'm going to turn it over to Dr. Zakari, and he will discuss treatment options for early pancreatic cancer.
Hi, everyone. I'm not sure if you can hear me. Can we go ahead and proceed with slides? My name is Dr. Zakari. I'm in Orlando, and my expertise is GI oncology. I had the chance to meet up with and work with Dr. Sar and do certain meeting with him and so forth. So we had a chance to run to each other in the GI oncology community. Can we go ahead and get to the next slide? So these are some statistics that actually most of us actually forget, and things have been evolving. The American Cancer Society actually estimates there will be around 60,430 people diagnosed with pancreatic cancer, and unfortunately, we're going to be losing around 48,200 people of pancreatic cancer. So the pancreatic cancer, actually, the likelihood of pancreatic cancer in the whole cancer is around 3%, and unfortunately, the 7% of patients, it represents actually 7% of patients' death from the cancer. It's called the silent killer. So just for some numbers for people to know, there is probably we diagnose around 280,000 women with breast cancer. We lose probably 43,000. In colon cancer, around 150,000, and unfortunately, we lose around 50,000. If you take out the smoker in any society, pancreatic cancer will be probably the second cause of mortality from cancer, next to colon cancer, which is around 50 to 52,000. Next. So when we talk about pancreatic cancer, kind of a little bit, we are concerned about the age, and the majority of the patients we see in the clinic, their age is between 55 to 75 and 80. We've been seeing more recently, kind of a little bit small number of younger patients with pancreatic cancer, and it's unclear why is that. I don't know if the environment, so we just kind of testing more, and you can see kind of a little bit throughout all kind of races and throughout all, the population that we have in the States, pancreatic cancer kind of a little bit, it's there on the right side of the diagram. You can see the incidence is slightly higher in the African American community, and we don't know why. Probably certain, changes the environment, but we don't know why. There is nothing sure about that. Next. When it comes to kind of a little bit, a risk of pancreatic cancer, what's believed to be associated with pancreatic cancer, age, as we get older, we are at high risk of having pancreatic cancer as any other cancers. Some of the kind of little bit, risks such as smoking, it has been always kind of debate. Obesity, diabetes, it has been always subject to the debate, and we don't understand what's really kind of the true relationship between diabetes and pancreatic cancer. It's an ongoing lot of research and work. Family history of pancreatic cancer kind of weighs our risk of having pancreatic cancer as individuals. And the main actually and the critical one is when a person has history of history of chronic pancreatitis. And the most common reason for chronic pancreatitis in our society, it has to do either to alcohol drinking or sometimes stone in the gallbladder that migrates and cause pancreatitis, or even stone actually in the duct with the tube that's in the pancreas, leading to chronic pancreatitis. Next. As Dr. Stark alluded to, there is actually a genetic syndrome, inheritance that we need kind of a little bit to always think about when we have patients with pancreatic cancer. If we think about it, all of these inheritances represent around 10% of pancreatic cancer. As Dr. Stark alluded to, probably the majority of them, around 3 to 5% actually of them, come from patients who carry the genetic mutation BRCA1, BRCA2, which is the most common genetic mutation we see in women with breast cancer, ovarian cancer. As it has been mentioned, it has to be actually now kind of standard to do the genetic testing, and to do it in 2 phases. The first phase, you do it actually in the cancer cell by itself, and then you do it through the blood when you go see your physician oncologist. Other gene that has been associated with it, which is also linked to breast cancer, is called the PARP2 gene. It's a newer type of gene alteration that we've been talking about. However, other kind of bits, genetic, as you can see in the slide. However, the one that actually you see most in our area of the GI cancer physician are the what you call Lynch syndrome, which is fairly commonly seen with patients who have polyposis, kind of a little bit, colon cancer with few polyps, leading to kind of lipids coming from some mismatch repair. And those particular patients with Lynch syndrome, that's higher risk of having pancreatic cancer. Next. So to understand actually the role of the pancreas has actually is critical, for us to know what's the role of the pancreas, because this has to do with the aftermath with the surgery and what comes along with after surgery. So the pancreas actually has 2 roles, has exocrine role and endocrine. The endocrine actually, which is, it makes the insulin, glucagon, so that means it really controls the metabolism of sugar in our bloodstream, and that is critical. And that's why kind of patients, when they do have pancreatic cancer, that's sometimes associated with some inflammation, and the pancreas by itself can start losing its function, and you can see the blood sugar shoots up very high. And sometimes even when those patients, when they go through surgery, they lose the function of the pancreas and they become really kind of a little bit, dependent on insulin. The second function of the pancreas, which is actually the one that's helped with the digestive system, mainly the fats, and through the certain enzymes such as the amylase and lipase, and they are actually critical into kind of a little bit, the fat digestive process in our body. Next. So this is something that's kind of a little bit, we kind of keep educating our the general population about what are the symptoms that may lead one think that he has pancreatic cancer. The most common actually symptoms that we see are generalized fatigue, weakness, and weight loss. And really kind of the majority of the patient, they have some unexplained fatigue and weight loss. The other kind of symptom that we see is the abdominal pain. Sometimes the pain actually feels in the back, and unfortunately, once the patient comes in with back pain due to pancreatic cancer, it has already kind of the tumor has already encouraged the nerve, the celiac nerve, and leading probably to that patient, he has a little bit more advanced disease than early disease. Jaundice happen around 60%, and so. And other thing that's actually very unusual, which is we see that rarely, which is blood clot. And blood clots, actually, they come in all different forms. They clots in the venous system, the arterial system, and that's may kind of made us think that patient has pancreatic cancer. Next. So what are the steps when a patient actually comes in and we think that he has pancreatic cancer? He comes in either with the jaundice or some changes in his liver function or her liver function. What are the initial diagnostic testing that actually the patient may need to go through? The most common one is ERCP, and the ERCP is a technique where gastroenterologists use the scope, and from the scope kind of a little bit, try to get into the biliary system. This is to delineate why that particular patient has jaundice or why there is abnormalities in the liver function test, as you can see in the pictures out there. The other testing that is also very helpful, very critical to what we do in terms of diagnosis of pancreatic cancer is the endoscopy ultrasound. And usually both of these testing, they are actually performed by not only GI, by interventional GI. The endoscopy ultrasound actually has few roles in what we do. First of all, it's established diagnosis by having biopsy, and one is give a sense what's the relationship to the tumor of nearby blood vessel. And as Dr. Starr kind of a little bit showed earlier, the pancreas is very adjacent to many blood vessels, and those blood vessels, they help us to make the decision should that patient go through surgery or not. And the endoscopy ultrasound give a little bit the first idea of what's the relationship to the tumor of that blood vessel. But also in those patients who may have a little bit more advanced disease, so they have severe pain, and it can help the gastroenterologist to perform what you call celiac nerve block, also known as celiac neurolysis, which helps quite a lot with pain. For those patients, for instance, or those who have family member pancreatic cancer, they have severe pain, always actually approach your physician. Is there any role of celiac block in my family member to alleviate the pain, and lessen the use of narcotics? Other things that we do is lab, and the most common one actually the tumor markers called CA19-9. That's what we do, and we kind of we talk quite a lot about that. There are a small group of patients that have normal CA19-9, and that's the way how it is, and kind of there is no way how to monitor that's marker. It's just their tumor does not make that protein. Next. When it comes to staging, this is actually the first session is to help us establish diagnosis. Now we have the diagnosis, we have to determine how far has the cancer gone to, and what we call staging system. The first one is the CT scan. They come into dual phase, triple phase, oftentimes called pancreatic protocol. It's easy for the radiologist to do. Some of the tumors, they may not be enhanced, they may not be better visible by the CT scan, so you may have to do the MRI. Some of the institution, as the Mayo Clinic had adopted, is probably the MRI is one of the kind of the testing to go to. In our institution, we start with the appropriate CT scan. If we have all the data, all the information, we try to avoid additional testing, except if there is some spots in the liver that is very unclear, and you want to kind of make sure that there is no cancer in the liver. PET scan, interestingly enough, for most of us probably, or in the GI oncology world, we don't use much of the PET scan except for particular cancer. In pancreatic cancer, the role of it actually is very limited. Usually you have all the information, the data from the CAT scan, honestly, and sometimes from the MRI. The PET scan, when you have that particular lymph nodes elsewhere and clear what to do with them, then you probably have the PET scan. In this particular case, in this particular patient, you can see the PET scan showed an uptake, and usually it's yellowish, and it's the one in the center. If you can just point the arrow to that mass that's with uptake, Daniela, please. So when it comes to kind of a little bit where we see the pancreatic cancer rising from, when it comes to the pancreas by itself, the majority actually of the tumor, they come out of the head of the pancreas, as the diagram kind of a little bit as you can see in the diagram. And as a consequence of that, there is a fairly higher chance of the patient coming with jaundice. Sometimes there is issue with the obstruction of the pancreatic ducts, which is the tube that drains the juice from the pancreas to the bowel, leading to diarrhea or what's called steatorrhea. Behind the head of the pancreas and the uncinate, there is actually some of the blood vessels there. They're critical. The main one is the celiac trunk, but behind it, there is the celiac nerve. And if the tumor kind of grows and it grows in the back and puts pressure on the nerve, so people, they come in with back pain. It could be either upfront abdominal pain, or it could be going to the back pain. The remainder of the tumor arises from the body and the tail of the pancreas. They represent 20–25%. Unfortunately, this cancer rising from the tail, when they are diagnosed, they will be diagnosed at a later stage, and because there is no pain, there is no obstruction, there is a little bit of diarrhea. When we see this patient, unfortunately we see them at a later stage. Next. So when we talk about the staging, we have, I'm gonna approach the very early stages. We say stage 1, 2, and 3, and then Dr. Hussein is gonna talk about advanced stage, we say stage 4. As you can see, when the tumor is very small, limited to one area, it's stage 1. When the tumor gets a little bit larger, above 2 centimeters, or it gets closer to the blood vessel next to it, as the second actually diagram show, it is stage 2. And when the tumor gets a little bit much larger and it goes into the nearby organs and it infiltrates some of the blood vessel, it is stage 3. Once the tumor sends seed and metastasizes elsewhere, it becomes stage 4, and that is the topic I think with the next speaker is gonna be sharing with you. Next. So from the practical standpoint, and oftentimes we get this question when we see patients earlier on, and the patient asks, Dr. Zachary, what stage am I in? And it's very hard because you just have CAT scan and you have MRI or blood work, and you know, for instance, how the tumor, it is there, it has certain size, there is some inflammation next to it, probably, you know, the tumor's size is a bit larger than the reality of it, and you try to explain to the patient, you may have this stage versus this stage, but the actuality of it, most of us actually, as oncologists, we group the stages into 4 stages from the practical standpoint. Can the patient have surgery upfront, called resectable? Is the patient possibly resectable? We need just some treatment prior to that, to downstage, to kind of make the tumor smaller and probably detach the tumor from blood vessel. Or the patient has locally advanced, where the tumor, it is invading, encasing the nearby blood vessel structure, but without distance, without metastasis elsewhere. Or stage 4, where there is advanced stage, where metastatic disease. Next. So how do we manage patients with pancreatic cancer? There are a few modalities. We kind of we hope all the time that surgery is the center of what we do, because surgery is the cure. Chemotherapy, this is something that I'm going to be discussing in a few slides. We can do it either after surgery or before surgery. The trend now is to do, honestly, chemotherapy before surgery, as it has been alluded to, for many reasons, and we're going to kind of review them, because you want to make sure that the patient is able to handle actually the chemotherapy. After surgery, there is chance that the patient becomes weak or never kind of recovers, so he doesn't get the chemotherapy. Furthermore, there is small chance that those patients may have some cancer cells elsewhere, and they end up being resistant, and they kind of they show up later. So it makes sense to not subject patients to major surgery if those patients end up having stage 4 metastatic. Radiation therapy, now the use of it actually is mainly before surgery. The use after surgery has been subject of debate. As a matter of fact, all data that was published many years ago actually, in Europe, they don't believe in radiation after surgery. They feel like it has negative impact. Or targeted therapy, that's what kind of a little bit Dr. Hussein probably is going to discuss with you guys, in addition to chemotherapy. There are newer targeted agents that's approved for the BRCA1 gene mutation, and so on. And other way how we manage actually pancreatic cancer when it comes to supportive care or just pain management or symptom management when we do celiac nerve block. Next. So as it has been alluded to, when it comes to pancreatic cancer management, it's not one man's job. Actually, it's multidisciplinary approach, it's team's approach. It starts usually with gastroenterologist, maybe the interventional gastroenterologist who does ERCP, endoscopy, ultrasound. They refer them to surgical oncologist and to medical oncologists, and with the help of the radiation oncologist at time when it comes to the probably getting ready for the surgery. At the end of the day, as has been alluded to, any patient or any family member who is diagnosed with pancreatic cancer, it has to be done really with multidisciplinary team, and everyone giving opinion. As probably you may have heard, most of the institutions that they do pancreatic surgery, large volumes, they have what you call tumor board, and they present cases prior to surgery, or even those who have had surgery, what to do after that. So that's the ultimate actually goal, how to manage patients with pancreatic cancer. Many physicians rendering, giving opinion with the center of all of that, how to manage, how to give the best care to our patients. Next. When it comes to surgery, the Whipple surgery, actually the old Whipple was very kind of a little bit, dramatic type of surgery. They used to remove the whole pancreas. It came down to actually, what if you do to remove just a piece of the pancreas, just head, you do pancreatic duodenectomy, and kind of a little bit you gain what you would gain from moving whole pancreas, but you know what? The function of the digestive function can be maintained. And there are two ways how to do the Whipple surgery. The most kind of a little bit, updated one, more recent one is the one on the right side, where they spare the pylorus and kind of they put it in the other side, which helps with the digestive system. Next. The Whipple surgery is mainly when the pancreatic cancer arises from the head of the pancreas, the beginning, where you remove just the first third parts of it. But when the pancreatic cancer comes out of the distal parts to the end of the pancreas, then you do what you call distal pancreatectomy. Anytime a surgeon will do distal pancreatectomy, has to remove the spleen with it. It's called splenectomy. And the reason being because of the blood vessel that actually comes to the end of the pancreas, at the end of it, are the same blood vessel coming from the spleen. As consequence to that, when you kind of clip that area, you clip also the blood vessel coming to or from the spleen. Therefore, the surgeon has to take spleen out. Before doing that, we have to kind of emphasize there are a few things that needs to be known. The patient needs to have vaccination. 3 vaccines that are critical, and they need to be done at least 14 days before surgery to allow maturity of the immune system to protect us from pneumococcal, Haemophilus influenza, and meningococcal. The Haemophilus, by the way, this is not the H flu, this is bacteria, actually can lead to major infection in the bloodstream, sepsis, what we call it, can lead to meningitis, can lead to major pneumonias as well. And meningococcal, it's mainly kind of a bit meningitis. Next. So when it comes to the chemotherapy, the role of the chemotherapy in early pancreatic cancer can be kind of a little bit, divided in 2 roles. One of it is after surgery, which is called adjuvant therapy, or before surgery, it's called preoperative chemotherapy, or also we call neoadjuvant therapy. As it had been mentioned, is the trend now is trying to kind of get all your chemotherapies upfront as well as the radiation if it's needed. So that way you want to make sure that the patient is really kind of the tumor size that's kind of a little bit shrunk down, and hopefully you're able the patient to complete his chemotherapy before surgery. The 2 most common regimen that we recommend in after surgery, the most recent one, actually a year and a half ago or so, is called FOLFIRINOX, which is stands for 5-FU, oxaliplatin and irinotecan. That has been actually the work of some of the European group and then the Northern American group, where it started with patients who have stage 4 pancreatic cancer. It turned out to be that it did a good job. So let's see, let's start it. Let's try it in patients after resection, and actually did much better job than what we had before. Prior to that, and the European actually also have published their data on gemcitabine, which is the oldest chemotherapy that had been utilized for pancreatic cancer, along with pill. It's called gemcitabine, and so on, and it had been approved since 2017. And both of them actually approved, but most of us actually use the FOLFIRINOX, except there is a major exception, use capecitabine and gemcitabine. Prior to surgery, there are two regimens. There is the FOLFIRINOX, the same regimen, and there is another combination of gemcitabine and Abraxane, and that's what I'm going to be discussing in the next slides. So what has been approved actually after surgery, which is the adjuvant, two regimen, the capecitabine, which is pill, is called Zolora, and gemcitabine, and that was actually the fruit of this clinical trial, is called the SPAC4, where prior to that, actually the median survival was around 18 months, probably 20 to 24 months. By having the combination of the capecitabine, which is pill, Zolora, along with gemcitabine, the median survival actually has gone up to 28 months. And from that point, actually, the publication showed that there is probably around 84 to 85% of patients made it throughout the first year, and 53 up to the second year. After that came actually the European, the French group, led by the French group, kind of utilized what they said, what if we use triple agents, use all what we have, all the 5-FU, the oxaliplatin, irinotecan, after the surgery. That actually, to our surprise, led actually to median survival. What surprises not the benefits, how was the median survival up to 54 months. If you see it, prior on the top, we were 28 months, so it's almost doubled the survival with that. It comes with price, which is side effect and certain side effects. But if you ask a lot of people to tell them, you know what, if I'm going to give you treatment that will probably double your chance of being with us than what has been in the past, here is the price for it, some of the side effects, some of the nerve damage, neuropathy, and probably diarrhea. Most of the people, they will say, I will take the risk and I will go with more, the chemotherapy will be a better chance to be, in the next 5 years with my family. Next. So, and this is the kind of a little bit the publication for people who have a little bit, want to make sure that, this is not something that's kind of came from small journals. It came from New England Journal of Medicine. It has been published there, looking into FOLFIRINOX with gemcitabine, and you can see the curves there. The red curve is the curve where they use FOLFIRINOX, and the other curve they use gemcitabine, and so forth. As you can see, in the second curve is they start actually really splitting and getting a little bit wider after the first 12 months. And that's actually where you need better chemotherapy, not only to help you be with us within the first 12 months, and thereafter, that's what matters. Next. So when it comes to the neoadjuvant chemotherapy, I also call it preoperative chemotherapy for pancreatic cancer. The rationale, as has been stated earlier, is hopefully reduction of the tumor size and minimizing the impact, the abutment or the encasement of the tumor on the vascular system. That way, it allows the surgeon to have clear surgical margins. That's one of the hope. It allows also those who have metastatic disease and declared, and seen to declare itself, and that's where you may probably avoid unnecessary surgery. As it's been stated earlier, which is we all believe that there is a large number, there is not large, there is number of patients when they do surgery, they never see the chemotherapy. At least if you give it to them upfront, you maximize the benefits of what you do as group between us, the surgeons, and the radiation. And it allows us to understand the biology. The two most common regimen is FOLFIRINOX, as alluded to, and gemcitabine Abraxane. We were part of the group that's actually published their data on gemcitabine Abraxane. We were lucky to kind of be in that group, and we showed that by using gemcitabine Abraxane as preoperatively in patients who have borderline or locally advanced, there is chance that you kind of render that patient surgical candidates unresectable. But most of us actually, or most of the oncologists believe FOLFIRINOX a little bit better. And the reason being is because they believe if FOLFIRINOX did a little bit better for stage 4, it probably do better also in preoperatively. That had been the thoughts until recently, just kind of a bit, toward the end of last year, go to next, where the next, please. Where there is this publication from actually the American group, the Southwestern kind of oncology group, they looked into which one is better, FOLFIRINOX or gemcitabine Abraxane, and it created a little bit, buzz and kind of a bit conflicting information, where probably if you were to choose FOLFIRINOX, gemcitabine Abraxane, probably it's the same. And there is still kind of a little bit, the thing is still ongoing. Now, why we say that's because oftentimes some of the patients, some of the family members, they feel probably their oncologist recommended chemotherapy less efficient and less beneficial to their family member or to themselves by themselves. Not everyone can handle FOLFIRINOX, I have to tell you. When we see a much older population or much weaker patients and so forth, and we believe they may benefit from chemotherapy prior to surgery, then using gemcitabine Abraxane may be fair and maybe also a good choice. Now, based on this, actually, the outcome may be the same overall. Next. So in addition to surgery, chemotherapy, radiation, the role of the radiation, since actually we start having using much better chemotherapy regimens such as FOLFIRINOX, we rarely use the radiation after surgery, except if the margins, the surgeon, left some of the cancer cells in the margins, and there is debate what to do with that. Now, the role of the radiation actually prior to surgery, and that's for those patients who may have what we call borderline resectable pancreatic cancer. In patients who have locally advanced pancreatic cancer, which is the tumor had already invaded some of the blood vessel or some of the nearby structure and so forth, we know this patient, there will be very less likely to become surgical candidates. For that, actually, radiation has a role to optimize local control and probably help with, pain management. The role, actually, radiation has a role mainly with, in patients who have pain, have advanced disease or so, where you use it as another tool to help with the pain, to minimize the need for narcotics and opioid and all of that. Then it can be, when it comes to prior to surgery, it can be given in two forms, either 25 to 30 fraction or 5 fraction. As you can see there, the kind of, when you go to the radiation oncologist, they have to map it out and so forth and kind of aim at the tumor by itself. Next. This is the future of what we do overall. The future of what we do is really kind of take the cancer cell and DNA kind of really kind of, or the DNA, and look into if there is any gene that's really kind of prompted the cancer to happen. Have we been lucky with pancreatic cancer? Not yet very much, but it's an ongoing kind of a lot of research. And the hope in the near future is if we can incorporate all of this targeted therapy early on into the management of patients with cancer overall. And this is kind of a little bit where most of the research is focused on is how can you add to what already have in terms of chemotherapy? Is there any role for newer agents, targeted therapy, or some of the immunotherapy if possible? Even though the data on immunotherapy pancreatic cancer did not pan out as good as we thought it's going to be. But this is where the ongoing work of, in the research world, and as Dr. Sarr had alluded to. Next. In conclusion, we have seen a rising incidence of pancreatic cancer. As you remember the slide that we had started with, there are probably 63 to 64,000. I have given a talk actually for PanCan 8 years ago or so, where the slide actually showed very interesting. It was 40,000. As you can see, there is a rise, and I don't know if it has to do with the environments. There is still ongoing research on that, or just we do more scans, or we as physicians probably we have better knowledge of how to diagnose, and there is breast cancer there is a pancreatic cancer out there that we need to think about all the time. Is there some genetic pattern? That's what probably the next speaker may probably approach with you, the BRCA1, BRCA2 gene. Anyway, when a patient is diagnosed with pancreatic cancer, in my opinion, it has to be done until multidisciplinary approach team. That particular patient's case needs to be presented in tumor board. There should be approach and discussion with the main physician, as it was said earlier. What define surgical candidates is the eyes of the beholder, is the surgeon by himself, and oftentimes we have debates between radiologist and surgeon. Does the tumor really kind of touch, or in case does touch, how much it touches the blood vessel and all of that. So hence the tumor, actually the patient's presentation in multidisciplinary approach is the best thing to deliver the best care to our patients. We need to define the stage after surgery, before surgery, to determine the need for chemotherapy. And then once you have the surgery, learning how to deal with your new digestive system. And hence the slide that's kind of always I went back to, what's the function of the pancreas? Actually, it's help digest a lot of things, including the fatty acid in our body. So therefore, if you do surgery and prior to surgery you do radiation, there is chance that the pancreatic function declines or may be completely lost, and therefore there is a need to have pancreatic enzymes to replace what's basically lost and to help with the symptoms. Emotional challenges. A lot of people, when they lose weight, it becomes very difficult for them to gain weight, and that translates to loss of muscle mass and other challenges comes along with that. And the best treatment option we always have to think about is for our patients is, can this patient go to the surgeon and get Whipple surgery? Because that's the only way how to cure pancreatic cancer. Should we use FOLFIRINOX? Should we use gemcitabine Abraxane before, or should we use FOLFIRINOX after surgery? All of that's kind of that's what we have to press. Should we add radiotherapy before surgery? This is kind of that's where multidisciplinary X-ray approach kind of helps to dissect what will be the best option for that particular patient. The future direction, as we always discuss, is the clinical trials. We need to be helpful thanks to the clinical trials. And with the newer agents we have, the survival of pancreatic cancer went from 6 months, 12 months to now in selected patients up to 54 months who had undergone surgery and so on. So this is kind of a little bit, an ongoing work of the research in all world of cancer, mainly pancreatic cancer. We need to think, how can we personalize therapy? And that's the future of, actually, in my opinion, and opinion of a lot of experts is managing patients with pancreatic cancer overall, including pancreatic cancer. How can we bring this targeted therapy to be used sooner to allow the patient to have maximum benefits and probably beat the pancreatic cancer overall. And that's, I will conclude my discussion, my slides here, and I will be around for any questions that you may have, and I will get the next speaker, give a chance to the next speaker to kind of to present his talk as well. Thank you.
Thank you so much, Dr. Sakari. That was very comprehensive. I love how you related a lot of the surgical, life after surgery for patients and need for pancreatic enzymes, and really made it relatable. So that was fantastic overview. So I would like to remind everybody, if Dr. Zakari's talk brought up any questions that you can think of, please type them into the questions box. And after our illustrious Dr. Hussein gives his talk here, We will, and actually after Raymond as well, we will be answering questions. So that's the best part of this whole presentation. So please keep the questions coming in. And without further ado, this is Dr. Hussein, who will talk about the treatment of advanced pancreatic cancer.
Thank you very much, Jason. So it's my pleasure to take the baton from you all. Some great presentations so far. So I'm going to talk a little bit about advances in advanced disease. So Dr. Zakari did talk a lot about localized pancreatic cancer, what you do before surgery, after surgery, whether you do radiation. So I'm going to focus on the large majority of patients with pancreatic cancer who unfortunately present at the first time they're diagnosed with fairly advanced disease, meaning that it may be inoperable or has spread to organs outside the pancreas. And I want to start with a patient case. This is a real patient who really changed the way that I think about pancreatic cancer. So, initially when I was starting off, I would really question whether it makes sense to give chemotherapy for somebody who has a diagnosis of advanced pancreatic cancer, because, you have to weigh, of course, quality of life issues, risk versus benefit. You have some toxicity and some cost that comes along with the treatment. And in many patients, they one of the questions that they have is really, is it worth the effort to go through this thing if at the end of the day, it may not help me that much. So this is something that I used to always debate when I saw a new patient with pancreatic cancer, until I met this patient. So it's a 42-year-old physician who lives in the Netherlands, who was diagnosed in 2010 after he presented with some abdominal pain and indigestion. And he did develop actually obstruction of his bile duct, so he got jaundiced. And at that time, he had a scan showing a tumor in the pancreas and dilation of the bile ducts because of obstruction, and then multiple spots in the liver, which looked like pancreatic cancer that has spread to the liver. So he had a biopsy done of the pancreas and the liver. Both of them confirmed pancreatic cancer, and he had a bile duct stent placed, so his jaundice improved. Next slide, please. So at that time, we just started using this chemotherapy called FOLFIRINOX. And for anybody in the audience who's ever had FOLFIRINOX, you will know that FOLFIRINOX is not fun. Chemotherapy in general is not really exciting. I don't think anybody wakes up in the morning saying, I'm very excited to go to chemotherapy today. And when you look at a curve like this, right, and I don't expect the audience to be experts in statistics to figure out what's going on here, but what you're looking at on the screen are curves that represent the patients who were enrolled on this clinical trial. So you'll see some bumps along the curve. The red line represents the patients who were treated with FOLFIRINOX. The blue line, patients who were treated with gemcitabine. So it was a half and half distribution of those two regimens. And what it shows is that the patients who were treated with FOLFIRINOX had less risk of death over time. But you can see that both of the curves actually come down close to zero. And some patients didn't die from their disease. So you can see that two little bumps out at the end of the red curve. So I don't know if you all can see that, but there are two little spikes at the end of the red curve. And when I saw this, I was thinking, well, I wonder who those patients are, those two patients who are out more than 42 months without a recurrence, who have received FOLFIRINOX in the past. So when I was thinking about this and I saw that patient, I was thinking about, well, could he be an outlier, right? And at that time, he was treated in Holland with FOLFIRINOX. And then he came to see me about 2 years later. It's a kind of an interesting story how he came to Miami. Can we go to the next slide, please? So he was treated with FOLFIRINOX. He got 8 months of chemo, and everything in his liver disappeared. The tumor in the pancreas decreased in size, and he stopped treatment after 8 months because of side effects. And anybody who has received FOLFIRINOX, I don't have to tell you that you get neuropathy, numbness in the hands and the feet, fatigue, sores in the mouth, diarrhea. There are many things that can happen, many bad things that happen with FOLFIRINOX, and you can't just keep beating people up with this chemotherapy forever. So when the chemotherapy was stopped, he had scans done every 3 months for the next 2 years. Nothing showed up on the scan. So this was now 2012, and he was trying to figure out what should I do now? Because at that time we never used to see this, right? When we had gemcitabine before, we give patients chemotherapy, it would work for a short amount of time and then it'll stop working. So we in Miami had recently published a paper on FOLFIRINOX, and there were not too many publications about FOLFIRINOX at that time. So he found me because he has a family member who lives in Miami, came here to Miami to see me. And, I presented this case in our tumor board and everybody was scratching their heads because, we didn't see this kind of thing happening. I had never seen this before where patients had developed a patient developed a complete remission, apparently on scans. So our group recommended just to keep monitoring. In fact, we recommended doing an endoscopy to biopsy the pancreas to see if anything was left there. But eventually he found a surgeon in Germany, took him to surgery. He had a Whipple, which is not something we normally do with patients who have metastasis. And he had no residual cancer in his pancreas, and the liver biopsies were all negative for cancer. So this patient, I lost his email address when I had moved from Miami temporarily. Let's go to the next slide, please. So I found him on LinkedIn and I sent him a message. He gave me permission to share his name. So this is his real name actually. And I sent him a message and this was his response. This was in 2015. He said, great to hear from you. I hope you're doing fine in Kentucky. I was at the University of Kentucky at that time. I just had my 5-year follow-up and the results are so great. It feels like a miracle. And he's still alive now in 2021, 11 years after his diagnosis with no evidence of cancer. So this really, back in 2013, 14, 15, when I found out that he was still alive, I started thinking, well, is it possible that we can cure patients with chemo? And then, when I started thinking about this when a new patient came, should I just kind of sprinkle them with a little bit of chemo and see what happens? Or should I push the envelope a little bit to see if I can get the next patient to respond like this? So let's move to the next slide, please. So how can we, so he's an outlier, right? Most patients who get FOLFIRINOX will not respond like that. But knowing that one patient that can happen to, and since that time, I've seen a handful of patients. We have a few patients in our practice. If you look at our social media feed and our website, you will see a few patients who have stories there, real patients locally who have been in remission now for 10 years after a diagnosis of metastatic pancreatic cancer. So our goal, and my goal as an oncologist, is to try to figure out if that can happen to the next patient in front of me. And that's what I try to do. And this is how we go about doing that. So I want all my patients to be outliers. Of course, that's not possible, but we try to investigate very, very deeply every single cancer to try to figure out if there are any vulnerabilities that you can exploit to beat that cancer. Now, in that particular patient that I just explained to you, we did not have routine genetic testing done. By the time we knew about molecular profiling, he had no cancer left, and the biopsy was too old to do anything. So we don't know what he had that would have led to such a great response. But now we are uncovering things that can help us predict, not in hindsight, but actually in foresight, to figure out if somebody is likely to have a response like that. So we're now doing routine profiling, and we do something called germline testing for every single patient now. Both Dr. Starr and Dr. Zakari alluded to this. Germline testing refers to testing of the patient, not the tumor. So germline testing, you want to know if you were born with any mutations that would increase your risk of pancreatic cancer. And it's not just for curiosity. We don't want to know this to say, okay, well, this is the reason why you develop pancreatic cancer. That would be good to know. But these are relevant for treatment, and I'll explain why in a minute. So in addition to doing testing on the patient, and this is something similar conceptually, if you go on ancestry.com and you request a kit to find out where your family came from, it's a similar kind of thing. We check your genes that you were born with to see if you were born with any genes that increase the risk of cancer. And BRCA, of course, BRCA is the most common one, but there are other less common cancers. In fact, I presented last year in the same webinar a patient with an inherited mutation called RAD51C who had an outstanding response, now 2 years out with metastatic pancreatic cancer in remission with no evidence of disease. So if you look at the tumors very carefully, sometimes you can pick up vulnerabilities that will help you. And then, of course, we do the tumor biopsy and we profile the tumor biopsy. And this profiling paradigm was really pioneered by the Pancreatic Cancer Action Network, who is one of the sponsors of this meeting, through the program called the Know Your Tumor program. So the Know Your Tumor program actually offered molecular profiling of about 1,000 patients with pancreatic cancer. And that really helped us to understand what mutations exist, what genetic changes exist in the tumors. And they also did germline testing or genetic testing for the patient themselves, not just the tumor. And that really added to our knowledge about what we can target. Next slide, please. So I don't expect everybody to memorize this slide, but this is a result from the Know Your Tumor publication. This was published back in 2018 by a very brilliant oncologist who's now at Hopkins, Dr. Pijvein. So what they found was that there was a group that I highlighted in the red box that have vulnerabilities in the cancer in repairing DNA damage. So every single cell in the body has to multiply itself. Well, I should say most cells in the body have to multiply themselves. And whenever you have all the genetic material being multiplied, inevitably you will get some mistakes in that process. So the cells, normal cells and tumor cells, have a mechanism to repair themselves from DNA damage. And we know from this study and from other studies that there's about 15 to 17% of patients with pancreatic cancer who have an inability to repair DNA damage. So because of that, if we start using DNA damaging agents like cisplatin and oxaliplatin, those could be potentially very effective in patients with these mutations. And BRCA is at the top of the list for those mutations. Next slide, please. So what they found was a curve, and I'm going to show you this in comparison to the previous curve that I showed, where if you have DNA damage repair mutations or problems repairing DNA damage, that's called DDR. You see the blue curve on the top. Those patients do better with platinum treatment, cisplatin or oxaliplatin, than patients who do not have those mutations. So this is a clue now that we can say, instead of having 2 patients out at 42 months, we have a few patients out at 18 months in this study. So maybe we are moving the survival curve in the right direction up. We can predict maybe some patients who are outliers. So previously, when you gave FOLFIRINOX, a few patients made it out 3 or 4 years. Now, if you give FOLFIRINOX to patients in this subgroup with the inability to repair DNA damage, then you may have more patients who are outliers. Next slide, please. And then we looked at not just DNA damage mutations in the tumor, but germline DNA damage repair mutations. And this is a curve of overall survival. You can ignore the one on the left. But this is a series from our institution. Dr. Palacio, who published this, was one of my fellows. And we found that in patients who had germline or inherited mutations that they were born with, most of these were BRCA, but we had some non-BRCA mutations. Those patients, actually, the curve is flat. None of the patients died in follow-up. So if you look at the green, I'm sorry you can't see my pointer, but on the right panel, the green line on top is showing you that really none of the patients who had those mutations died in follow-up. So if you go to the next slide, I can show you what the comparison is now. So on the left panel, unselected patients means that you take every single patient with pancreatic cancer and you see what happens with FOLFIRINOX. Most patients drop off the curve because they die from cancer. Some patients are outliers. Then in the middle, you have mutations that were detected in the tumor, which impair the ability to repair DNA damage. So we have more patients surviving longer. And then on the right panel, if those mutations you were born with, you have even better survival. So if you look at the bottom of the screen, the 1-year survival rate with FOLFIRINOX is less than 50%. If you give FOLFIRINOX to somebody with a mutation like this in the tumor, the survival rate goes up to 60%. And then if you were born with a BRCA mutation and you get a platinum drug in the first line, your 1-year survival rate should be very high. Now, in our series, it was 100%. I don't expect it to be 100% across the board, but this is what we're approaching now with platinum treatment in patients with BRCA mutations. So again, the reason why we give chemo is not that we want to push the curve by 3 months to say, okay, well, I'll give you 3 months extra of life. It's because some people, 5 years ago, 10 years ago, when my patient Andreas was diagnosed, we had no clue about DNA damage repair mutations, but he probably had one and he benefited tremendously from that drug. And we're still learning about the disease. So we give these treatments to try to see if we can produce the next outlier so that we can have patients living long, productive lives, seeing their grandchildren grow up. These are the kind of things that we want to achieve for patients, right? So when I'm treating a patient, I'm not looking at them as a statistic to say, okay, well, we'll probably help you a little bit. I want to have that patient be the next outlier. And this is what I'm trying to show in this in these curves here. Next slide, please. So these are the averages, right? So with gemcitabine back in the day, we could probably get an average of 5 or 6 months out of it. With Gemzabraxane, we can probably get about 8 months, and for FOLFIRINOX, about 12 months. But these are limited, right? And what we're trying to do is now dissect the whole population of patients with pancreatic cancer into small groups where you say, okay, if you have a BRCA mutation, this is how we treat you. You probably do very well. If you have this mutation, we'll treat you. You probably do very well. So we really want to beat these averages, all right? But still, unfortunately, this is what the average looks like. But again, we're really trying to identify those people who will be outliers. Next slide, please. So what is there beyond chemotherapy? The most recent drug which is approved for pancreatic cancer is a drug called olaparib. The brand name for that is Lynparza. And this is a drug in a category called a PARP inhibitor. And PARP is an enzyme which is also responsible for repairing DNA damage. So this cartoon is showing you on the left panel 2 systems for repairing damage to the genetic material. BRCA is a system that helps to repair DNA damage. PARP is a system that helps to repair DNA damage. And if you go to the right side of the screen, if you have in the dotted line, the red box with the dotted line, if you look at, thank you, if you look at a tumor cell that has a BRCA mutation with the red X there, and you treat with a PARP inhibitor, you basically have 2 systems for repairing DNA damage that are shut down. And because of that, the cell will die. And that is a theory that led to the approval of olaparib. Next slide, please. So this is this study. We participated in a study called the Polo trial, where patients received chemotherapy first for about 4 months, and then they had a randomized assignment to either receive an olaparib or placebo. And there were 154 patients who were randomized on this study. And these 154 patients really helped to move the standard of care forward in this disease. A lot of patients are hesitant about getting into a randomized study. We had a few patients who were hesitant. They tested positive for BRCA, but they didn't want to be randomized. And we are very grateful for the patients who did go on to be randomized on this study. And now we know that olaparib is better than placebo, and it's widely used. And in fact, the patients who were on placebo eventually were able to get olaparib later on. So this led to the approval of olaparib, and this is another treatment option we have. And it's an oral medication, very well tolerated. And I have some patients, in fact, one patient who was on the Polo trial, I'm still treating 4 years later on olaparib without any evidence of disease. Next slide, please. So this is what I was saying. We are trying to dissect the disease now into small groups. We have a genetic change called microsatellite instability, and there are 2 immunotherapy drugs. Unfortunately, that only happens in about 1% of patients with pancreas cancer. There's a specific genetic mutation called NTRK. We have a very good drug for that. There's a tumor characteristic called TMB high. If you have a lot of mutations in the tumor, immunotherapy can work. We mentioned BRCA with olaparib. And then there are other targets that are relevant in other tumors that infrequently happen in patients with pancreas cancer, and we can target those as well. So I hope I've been able to convince you that we're making some progress. We have seen some patients do very well, you know, and you, I think as a patient, you would want your oncologist to really investigate deeply and leave no stone unturned to find out if there's any vulnerability of the cancer that you can exploit for treatment. So I'll stop there. I went, I think, 2 minutes over time, and I'll turn it back over to Dr. Starr. Thank you.
Thank you so much, Peter. I love the patient anecdote and sharing that patient's story, and that patient allowing you to provide their name, and you know, so folks can see that, you know, that's a real person that is, you know, cancer free this many years out. I think you said 12 years, which is just amazing. And ultimately, you know, instilling hope and the fact that, emphasizing the fact that we need to look for, do the genetic analysis of every patient with pancreatic cancer. Otherwise, we won't find these mutations and can't make the impact that we want to. So next, please continue with the questions. We're getting some in, so thank you very much. We're going to hear from Raymond Penn, and he is going to discuss with us patient assistance programs and caring for the caregiver. Vitally important.
PanCan has been helping patients and families affected by pancreatic cancer for over 20 years. And all of our programs and services are offered for free of charge. The Patient Central is a one-stop shop for people facing this disease. People can go, they can call, or they can email and get free information. And the information they'll get is like a list of the cancer specialists in their area, a personalized clinical trial search, it'll help them do that, diets and nutritional information, local support groups, and other resources like financial assistance that may be specific to where they're living at that time. It also has free educational packages that can be mailed out to them to help them make some critical decisions. Now, PanCan also offers some free resources and materials to healthcare professionals. Those can be ordered online, free at https no-click meal at www.pancan.org for healthcare professionals. You can go on the website and you can find that information. Also, Patient Central, like I mentioned, can be contacted at phone number 877-272-6226. And you can also find them, like I mentioned, at patientcentral@pancan.org. Now, there's a few big programs that we call out at PanCan. Know Your Tumor, like was mentioned earlier in some of the program. Know Your Tumor is a precision medicine service that provides patients and their oncologists with information about patients' biology through tumor tissue, biomarkers, testing the genetic testing for inherent mutations. Knowing Your Tumor gives patients and their healthcare team access to information about treatments, including available clinical trials. And they are personalized to that individual, for them personally. PanCan patients who are able to go to therapy and match their tumor biology live an average of at least 1 year and longer compared to patients who don't. So another program that's offered, one of the bigger programs, is Survivor and Caregiver Networks. We know peer-to-peer and one-on-one support matters. PanCan Survivors and Caregivers Network connects patients and caregivers with peers who know what they're going through, who have experienced it themselves. Now, professional advice and guidance matters on this journey a lot. That's very important. But so does talking with someone who's been where you are and who has gone through the same thing themselves. These personal connections is so important, and it really helps individuals get through, similar to me. And if I have time in the end, I'll love to share a little more about my story. Now, there's a patient registry also. The patient registry is a global online database created to look for patients in treatment, side effects, management, and diagnosis that will lead to improving treatment options and outcomes for patients. When patients join this community and share their experience, they give researchers access to critical data that help make discoveries. Whether they're patients and caregivers, the contributions are meaningful. Together, we have more pancreatic cancer research moving forward. We have 5 volunteer affiliates here in Florida, which is Jacksonville, Central Florida, down in Orlando, Tampa, Broward County, Palm Beach, and Miami. Now, our volunteer affiliates is the reason that PanCan call itself a national organization. They bring the work out to the communities across our country. The affiliates work with raising awareness, advocacy, survivor, caregiver engagement, media and communications. There's education and outreach. The raising funds through the Purple Stride events, and the affiliates are volunteers driven, and we're always looking for more volunteers to join our effort. You know, 5 years ago, my wife was diagnosed with pancreatic cancer. And that's when we first got affiliated with PanCan. And they gave us a lot of information. She wound up, after being diagnosed, living 3 years after that. And I made her that promise that I would stay involved and do whatever we could do to help people that are affected by this deadly disease. And that's why I'm involved with this organization. This was my high school sweetheart. We were together for 36 years and friends for 44. So I want to do everything we can, and PanCan is an awesome organization, is pushing this effort to make improvements on the survival of this deadly disease.
So I wanted to talk a little bit about disparities. I can't emphasize how important this topic is enough. Couldn't do it justice in a few sentences. But cancer affects each population of patients differently, and minority groups in the United States bear a greater burden for many cancers. Flasco is actively fighting cancer disparities on many fronts. On your cancer journey, you can do your part by making sure you just ask. Help us narrow the gap. To learn more about cancer disparities in pancreatic cancer, please download our Disparities in Pancreatic Cancer slide packet and Minority Cancer Awareness handout located in the handouts drop-down box on your go-to webinar panel. And actually, Flasco is dedicating a whole meeting to cancer disparities. So really appreciate the work they're doing to highlight the disparity that exists and to help those who may be marginalized. We will now move on to the question and answer portion of the webinar. So panelists, please go ahead and turn on your webcams. I'll go ahead and read the questions, and I will allocate or kind of divvy up the questions among ourselves. And I'll go ahead and start with the questions. So the first question is, if we do ask a surgeon how many Whipples they've done, how many would be a trustworthy number? So how many Whipples would you say, oh yeah, you know, this surgeon is well versed in Whipples and does enough? So maybe Ahmed, can you take that one?
It's a very tricky question, Jason, as what's defined an expert surgical center is the number of the pancreatic surgeries are performed at center. And that number begins at number 40 and above. The highest number we have in the United States is 340 and 50 per year, pancreatic surgery per year. This is somewhere in Johns Hopkins. And so forth. So a good surgeon by himself, the one who's done probably above 15 to 20 per year, who does 15 to 20 per year, is a very good surgeon. very good surgeon. If you do be above that, probably will be just icing on the cake. But ultimately, it's not only the surgeon by himself, actually, it's the whole surgical team that's come along with him. So you want to ask not only about how many surgeries you have done, how many surgeries, how many pancreatic surgeries, Whipple surgeries have been performed in your center, in the hospital where you practice.
Yeah, I would completely agree with you, Dr. Zakari, on that number. I think the gold standard's been considered 12, so one a month at least. So you want to, make sure your surgeon is doing at least one a month. More than that was favorable, and as Dr. Zakari mentioned, being at a center that can anticipate complications is equally important. So the institution, the nursing staff, and so on and so forth, who are going to be taking care of these patients after the surgery. Next question is, what are the chances of a pancreatic cyst becoming cancerous? Which is a good question. I'll take this one. So the pancreatic cysts are complex. They depend a lot on the appearance on imaging and the size, where they're located in the pancreas. There's some pancreatic cysts where we can confidently say that this has a very low chance of being malignant, and that would be something like a serous cystic tumor, right? And so, even imaging characteristic wise, we could confidently say that. Now, otherwise, there are some investigations that can be done to further delineate, or further expound on what this cyst is. So one is, is the main duct of the pancreas dilated? So that'll give us some information. The other thing is, as Dr. Zakari had pointed out, the endoscopic ultrasound is sometimes helpful. That will give more imaging characteristics on the ultrasound. Sometimes we test the cystic fluid, the fluid inside the cyst, to determine its malignant potential. And so there's a bunch of predictive factors in terms of the size of the cyst, again, if the main duct is dilated, the appearance of the cyst. So all that goes into determining what are the chances that it is potentially cancerous. And if it is deemed that there is a chance of cancer, a significant chance, you could say anything, greater than, you can arbitrarily say anything greater than 5% would be a reason to take it out. You could say anything greater than 1%. But in any case, there are cutoffs to determine that, and as I alluded to. So the next question, Dr. Hussain, this is right up your alley. What are some clinical trials that you are keeping your eye on?
So great question. There are a number of studies ongoing right now in advanced pancreas cancer. So if you look at the localized setting, if somebody has operable pancreatic cancer, I think one of the most important clinical trials ongoing right now is a trial being run in the US, where people are being offered surgery first versus chemo first. That's being run through the National Cancer Institute Clinical Trial Network, through a group called the Alliance for Clinical Trials Network. So patients who have clearly operable disease, we are presenting that study to them, where some of the patients will be assigned to surgery first, followed by chemo, or chemo first, followed by surgery. And it may seem like a simple question, but I think that is something that is likely to move the standard of care if the result is what we believe it will be, potentially improve survival. That's what we're trying to achieve. There are other studies looking at incorporation of radiation if the disease is borderline resectable, and there's a sort of a national consortium trial ongoing right now looking at a type of radiation called SBRT, or ablative radiation therapy. That using a new device. So many centers are involved with that study, including ours. There's also large studies testing a modality called nanoknife, other types of treatment delivery to the pancreas in patients who have unresectable but not metastatic disease. So those are I think some of the larger trials ongoing right now in the US for localized disease. And in the setting of advanced disease, Raymond alluded to this. The Precision Promise, I think, is really a platform that is moving the standard of care, or trying to move the standard of care forward. So Precision Promise was designed by PanCan and a group of scientific experts from many large centers across the country to try to bring clinical trials to people all over the country, right? So now there are 20 sites around the country that have these studies available for patients with metastatic pancreatic cancer. And right now, there's one of the arms of the study testing a drug called SM88. There's another arm of the study testing an antibody called pamrevlumab. And there will be another one coming up soon with a drug called canakinumab, which is a type of immunotherapy in combination with a PD-1 inhibitor, which is another type of immunotherapy. That looks very promising. There's a lot of good science behind that. But it's not just these individual studies. The Precision Promise program is a platform for bringing in promising clinical trials to deliver them to patients around the country. And the idea is to be able to accelerate progress. And we are now turning down studies that would compete directly with Precision Promise because we want to focus most of our efforts on that to really try our best to move the field forward. And I would encourage people to go to PanCan. PanCan, apart from these studies that I mentioned, they have a very good program where they can match patients to appropriate clinical trials. You just need to give some basic information about your stage and where you are in your disease, and they can give you a list of options. And I have patients who come to me with these lists, and we go over which ones are appropriate, which ones are not appropriate. But for somebody who's not an oncologist, it's sometimes hard to figure out which is the best study. So you really need to discuss that with the oncologist to help you make that decision.
Love those insights. Thank you, Peter. One that I'll add is a type of immunotherapy. It's a CD40 antibody, something that came out of, I believe, UPenn in collaboration with the Parker Institute for Immunotherapy in California. But there was some really exciting data that really was all over the headlines in 2019. So we're anxiously awaiting some of that phase 2 data, which actually is supposed to be reported out this year. So that's another one that I'm keeping my eye on. So great question and great insight by Dr. Hussain. So I'm going to give this one to you, Dr. Zakari, if you don't mind. Are there any types of treatments that prevent us from getting the COVID vaccine?
That's actually, in terms of chemotherapy for pancreatic cancer, the answer is no. So just for the audience, and the ASCO, which is the American Society of Clinical Oncology, when the FDA had approved COVID vaccine and the government gave the green lights, the ASCO actually went back and forth what to do with our patients with COVID. The conclusion that they come up with, most of the chemotherapy may probably render the patient slightly myelosuppressed, but his immune system is not severely depleted to prohibit him from having COVID vaccine. And because of that, they don't see, and personally, we don't see a reason why the patients on therapy or just during therapy or after therapy not to receive COVID vaccine. There are some of the kind of challenges, but we may not apply to patients with pancreatic cancer, such as patients with acute leukemia, patients with graft versus host and other cancer therapy, but not for pancreatic cancer. And keep in mind, pancreatic cancer, even with chemotherapy, the one that may probably render the patients immunosuppressed and low white blood cell, low immunity, it does that only for a short period of time. So the white blood cell immune system has to recover to be ready for the next treatment. So what we have done is what we have recommended, if that particular case, the patient can receive the vaccine in that period where you feel the white blood cell is up and his immunity is back to normal.
Yeah, that was excellently put, and I really don't have much to add to that. Dr. Hussain, have you been advising your patients to get the COVID vaccine?
Absolutely. And not only the patients, but all their family members.
Love it. I would advocate for the same. So the next question is, I have a mutation in a gene called BRIP1, B-R-I-P-1. My oncologist said olaparib, which is, as Dr. Hussain talked about, a PARP inhibitor, might work for me, but she wants to reserve it for when my current treatment stops working. Not added on now, and she would like our opinion on this. I'll mention, I think this is right up Dr. Hussain's alley with his presentation. BRIP1 is involved in DNA damage repair and was, I believe, included in some of Dr. Pashivian's work in terms of one of the DNA repair mutations that they looked at. One other thing that I'll mention is that a lot of these genes, there was some data that suggested, for example, the BRCA gene, that once patients are on chemotherapy and have developed something called platinum resistance. So one of the drugs that we use in pancreatic cancer is called oxaliplatin, that once patients develop resistance, so the drug stops working against the cancer, the PARP inhibitors tend to not work as well. So that's something worth mentioning in terms of waiting. However, one option would be to potentially offer it in a maintenance setting, understanding that the FDA approval is for BRCA mutation, germline BRCA mutation. So this would be off-label and very outside the box. Dr. Hussain, I'd love to get your thoughts on this.
Sure. So I agree with everything you said, Jason. So if when the PARP inhibitors were first being developed in pancreas cancer, one of the initial studies was done in patients who had progression of their cancer after receiving chemo, so what we would refer to as refractory cancer. And the responses were not so great in that population. And we sort of borrowed a concept from ovarian cancer where patients received chemo first and then went on to receive the drug, the olaparib or Lynparza, as maintenance. And it seemed to work better in that situation. And there have been other studies, both in pancreas cancer and breast cancer, where people have tried to combine PARP inhibitors with chemotherapy. And it doesn't seem to be very successful doing the combination. So the sequence of chemo first followed by the PARP inhibitor seems to be more successful. And that is what we normally do. Of course, that is not what the drug is labeled for. It's not approved for that. But I think it would be a reasonable approach, understanding the toxicities of the chemotherapy. If you hit a wall with toxicity, with side effects, then I think it would be reasonable to pursue this. And there was a study recently published by the MD Anderson group, Milan Javli, in collaboration with Talia Golan from Israel, where they put together a number of patients who had mutations similar to BRCA, what they call a BRCA-ness study, or mutations that were not exactly the same as what was included in the POLO trial. And they found some benefit in some of those patients. And it was used in a maintenance setting, similar to what the POLO trial did. And I had 2 patients on that study who derived some benefit. So I think it would be reasonable to consider it as maintenance after, if you reach the limit with the chemotherapy, then I think that would be an appropriate situation to consider that drug.
Great insights, providing some data.
Jason, I have to add, Jason,
please.
I have to add really kind of a little bit what Peter had said in terms of maintenance therapy. Oftentimes, some of the oncologists they want to continue the patient on systemic chemotherapy until there is complete kind of a little bit maximum response and resistance where there is progression of the disease. But we forget that, patients are at one point of time, the chemotherapy becomes very challenging. And hence the word de-escalating maintenance in certain cancer. In this particular case, it seems like, probably it's wiser if the patient had maximum therapy around 6 months, whatever chemotherapy was working for her. It makes sense probably to go back on maintenance therapy for two elements: to minimize the side effects of the chemotherapy and to allow the oncologists have always another tool to go back to the same chemotherapy if the cancer were to progress in months or years from now, because that disease never progressed. This is something that probably the person who asks the question may address with his or her oncologist is, what if you de-escalate and do that on maintenance therapy? And we know that, as Dr. Hussein alluded to, the role of PARP, actually is published by the Polo, is maybe kind of maintenance therapy. This is something that's probably practically may make sense. I don't know, what do you think, Jason or Peter, about it?
No, yeah, I completely agree with your sentiments. Yeah, I mean, chemo eventually wears out its welcome. You know, quality of life starts to decline, inversely proportional to the amount of time that somebody has been on chemo. That's just the nature of being on chemicals. So if there's another drug that could potentially offer better quality of life, it's a pill, certainly, you know, quality of life reigns supreme. I will say PARP inhibitors can have some side effects, but certainly, in my experience, less so than some of the IV therapies. And then again, offer that, you know, you don't feel so like I'm in clinic all the time, planning vacations, so on and so forth. Any thoughts, Peter?
Agree.
Okay. So thank you. So I have I really like this question. So why isn't the tumor genetically tested before chemo is started? Wouldn't the doctor know better what medicine to treat with? So Dr. Zakari, you want to start with this one?
Jason and Peter, you know, our take on it is, that would have been probably ideal, and two elements in it. I think the future of medicine will be that way, where we take the cancer cell, kind of a bit split up and look into the genes that's actually turned on to initiate the cancer, and to see if there is targeted therapy up front. So why would you subject patients to chemotherapy if we think that targeted therapy can give you the same result with minimum side effects and many convenience taken? Also, most of the targeted therapy, all of them actually are pills. Two downside to that. The first downside to that actually is the payer. Oftentimes the payer is not willing, which is the insurer is not willing to pay for the information that you will get from the genetic testing, from the molecular profiling from upfront. They would like to see some chemotherapy where the patient had failed and so on chemotherapy. Number one. Number two is, unfortunately, not all cancers, there is identifiable genetic alteration that can be targeted. And our luck with pancreatic cancer has not been as good as certain other cancers, such as lung cancer or melanoma or kidney cancer or so. So because of that, I think ideally, if you were to ask the oncologist probably a few years from now, where the world of oncology had evolved to a more targeted therapy based on the molecular profiling, this answer will be much easier. But right now, it's very, very challenging from different sides. We don't know if the targeted therapy will get you as much benefits as what has been published in chemotherapy, number one. Number two, honestly, it has to do with the conflicts of, can the payer afford that particular drug that you will get from the genetic testing. That being said, should you do it upfront and use that information later? I think most of what that's what they do. Some of the physicians, they like to use it when they're start running out of the approved chemotherapy options. But really, there is no clear data to help you where to go with that.
Dr. Hussein, how is your practice? Are you doing genetic testing up front if you have enough tissue, which is always a challenge as well when you're getting a fine needle aspiration or a core needle from a EUS, endoscopic ultrasound? What's been your practice?
Yeah, so we routinely send the genetic testing at the time of diagnosis. That the issue with waiting for the result is that many patients, when they come in, they're very symptomatic, and you have a small window of opportunity to treat. And we know that chemo has a best track record. Even though chemo is not fun, I usually tell the patients, this is what works the best as far as we know right now. This is what we will start with. And if we find something very promising on the profile, on the genetic profile, we will discuss what we do with that information if we consider making a change. And if it's something that is very promising or proven to work, you may consider changing from the chemo. But if you wait for the results to come back, sometimes it can take 3 or 4 weeks, and you have some patients who may decline during that time. So that's another factor that we take into account. But we do genetic testing. I think most oncologists will do routine genetic testing up front, but it's challenging to wait for those results because I would say the majority of patients will not have a genetic marker that you can go after, and you will end up kind of losing time in the majority of patients. Sometimes you get lucky and you find something and you can run with it. But we usually try to get the patient started as quickly as possible and then adapt as the information comes in.
Thank you guys for your insights. Yeah, I do the testing up front. If I have enough tissue and it's localized, because if you get to surgery, which is always the hope, then obviously you have a lot more tissue to send for genetic testing. I do try to do the genetic testing at diagnosis. I do the germline testing, the blood test, and the testing of the tumor sample in parallel. There's a lot of different companies and platforms that offer that. You could say, well, if you're giving chemotherapy anyways, and is it going to change your management at that moment? Potentially. We have some data suggesting that, obviously with the FOLFIRINOX, the platinum is the important drug, the more important drug when you're talking about DNA damage repair deficiency. In effect, BRCA, gene called PALB2, a gene called ATM. But now there's been a little bit of a push for, and I don't know if you guys are seeing this as well, but with the data, gemcitabine, Abraxane with cisplatin. So another triplet incorporating the platinum. So again, if you have a DNA damage repair deficiency gene, whether it's inherited or acquired, what we call somatic, it may have some implications on your chemotherapy choice. But I think the bottom line is, at some point, the testing should be done. It may be a bit controversial whether you do it right at diagnosis or you wait until a patient develops more advanced disease. That's probably a discussion.
But Jason, just to clarify for the person who asked the question, is probably all of us who are speaking same language, but the person who asked, if we are talking about the genetic testing looking into the BRCA1, BRCA2 other genes, that's actually had been and should be standard of care to be upfront. If you're doing molecular profiling, which is the genetic alteration in the cancer cell, that's what kind of a bit with kind of refers to is you may not see an oncologist order it upfront. Most of us probably we do who have interest in the GI cancer world, they do it upfront, but you might not see it. But as alluded to is, when for instance, you have chemotherapy that works, you're waiting for it to start working to use that, that's probably the rationale from other oncologists I've spoken to. But when we talk about the genetic testing for the BRCA and BRCA2, actually that's, that should be upfront.
Good points. Thank you for the clarification. So I think we're getting close to the end. Let's see here. I think there was one more question that maybe I'll kind of tackle here. My oncologist said if you stop specific chemo and go back again, it won't work again. So that's not necessarily true. What is true is certainly if you were on a chemotherapy and there was some progression, if you went back to it again, likely wouldn't work. But there's many times where we stop the chemotherapy, we do a chemo holiday, and then there's some progression of the disease. If that chemo was working, we would go back to the well again. Certainly you may not have as robust of a response as you did, at first, but certainly there could be some benefit there. And we want to get as much mileage out of the treatment as we can. We don't have as many options as I'd like, but that's why we have clinical trials. So we want to make sure that we don't prematurely stop a therapy, or I should say, we don't disqualify a therapy that may still have some benefit. But thank you. These are such good questions, very intuitive, insightful questions. I think that'll help a lot of folks that maybe didn't think of the questions. So I want to wrap up tonight's question and answer, and thank our panelists for just pouring their life's work into taking care of patients and trying to move this field forward. And so there is a presentation by Dr. Diaz, which talks about access to quality care, pharmacy benefit managers, additional support resources that is made available through the Flasco patient portal. And it's really important. He gives a lot of different resources, and he's an excellent speaker. I think you would enjoy it. So please take the time to watch that. If you'd like to be added to our mailing list for Flasco, there's a lot of patient advocacy group, events going on during the year. You could share with any friends and family. It's info@flasco.org. And again, I would like to thank everybody for coming tonight. I'd also like to thank Ipsen and PanCan for sponsoring the webinar. We're very grateful to have this platform to be able to discuss these advances that we're all excited about. And remember, the webinar was recorded, so if you missed anything, please, we'll have it on Flasco website soon. And I'll leave you with some parting words of, there's support out there, there is hope out there, and lean on your friends and your family and your faith to carry you during a difficult time. And as your oncology team, we want to be there with you in the trenches, and we want to guide you to help you make decisions and be your partner to make informed decisions together. But no one has to go it alone. So again, thank you all, and hope you have a restful rest of the night.
Thank you, Jason. Thank you for the great webinar, and thank you for the Flasco, the PanCan for kind of inviting us to be part of the panel. Great discussion, and I hope we've been helpful.
Thank you.
Hello, I'd like to welcome you to the advocacy portion of our Flasco Living with Cancer series presentation tonight. My name is Michael Diaz, and I'm a medical oncologist and hematologist. I'm the Flasco Director of Patient Advocacy and a past president of Flasco. I practice medical oncology and hematology in St. Petersburg, Florida with Florida Cancer Specialists. And we're here today to talk about something that's pretty near and dear to my heart, and it has to do with patient advocacy. And so first of all, I'd like to start off more from the big picture perspective. I've had people tell me in the past, well, Mike, talk about advocacy. Tell them what it means. Well, I looked up the definition of advocacy in the dictionary, and all it says is to advocate. Very helpful, huh? So let me just explain. So advocacy, as far as I'm concerned, yeah, it's a general concept, but it means to advocate for, which means you're trying to do something to benefit somebody, whether it be yourself or somebody else. In fact, you all being here tonight to educate yourselves means you're advocating for yourself in the form of education, educational advocacy about a condition that might mean something to you or someone you know or care about. So yes, there's educational advocacy. Your doctors will also most likely advocate for you whenever they're fighting insurance companies to get scans or medications or therapies or testings approved. We really don't get paid any money to do that, and that's we either have to hire staff to do that or we do a lot of it ourselves too, but we're advocating for you. The way, and there are many other ways besides education, you can advocate for family members. You can help assist with certain components of their care, and all that is advocating. There are lots of ways to do that. The main way that I like to advocate for my cancer patients because that's one of the reasons why I love being a doctor. In my free time, which is not a lot of, but I do spend a lot of time doing it, is I advocate for my patients when it comes to healthcare reform. One of the things that I noticed as I was going through my training as a young oncologist is that it didn't seem to me that there were a lot of healthcare providers involved with the policy decision-making process that would impact patient care, patients' healthcare, or their access to care. And one of the things that I've been doing since I've been practicing medicine for a little over 15 years now, I've been getting more and more involved with advocating for healthcare reform so that patients have access to affordable quality healthcare that's close to home. I'm a firm believer that we have enough resources in this country. There's no reason why people shouldn't have to spend their life savings or refinance their house just to get their cancer care. I think it's ridiculous. I personally think that the system is flawed in a lot of ways. And I think that there are a lot of people who are getting a disproportionate share of the resources, and those are not the patients, and I personally don't think they're the providers either. So that's one of the reasons why I'm involved with healthcare reform. And we do it in a lot of ways. I work with organizations of like-minded individuals, whether it be other oncologists or pharmacists. We have organizations. We work to advocate here in Flasco, mainly at a state level and also at a national level. But I do work with other organizations for synergy. And it all has to do with in understanding the healthcare system, which is extremely overly complicated. It needs to be fixed, but it's what we have, and we have to understand it to understand where the problems are so we know where we can fix things. So if we need to, instead of guessing, we will perform studies or commission studies to be done to better understand the little nuances of how potential things are impacting patient care or access to patient care. And then we also spend a lot of time educating our elected officials on this process, whether it be local in Tallahassee, whether it be going to DC, which we don't do a lot of traveling now, but I previously I would go to DC at least twice a month to help educate our elected officials there. We have to network a lot with Health and Human Services as well as Center for Medicare and Medicaid Services. And at a state level, we have to work a lot with the governor's office, the insurance commissioner, as well as Florida Medicaid for a lot of patient issues. And just to give you an idea of how effective you can be sometimes, for those of you all that aren't aware, about 4 years ago, the previous administration attempted a demonstration project that we will call the Part B Medicare Demonstration Project. And they thought, oh, we're going to save money. We're going to reduce the cost of care. And unfortunately, all it would have been doing was restricting access of care to possibly 50 to 75% of Medicare patients across the country, because it basically refused to pay for the more expensive treatments. Well, if you have cancer, you know that a lot of the time, the most effective treatments are the more recent treatments and are going to be the more effective treatments. Well, they were going to try to encourage you to use more generic medications. Well, the generic medications in cancer care are over 10 or 15 years old, and they're fairly outdated and not usually as effective as the newer medications. So it would have negatively impacted patient care. We went to grassroots across the country. We had to have all of our patients contact their representatives and their senators and tell them that they needed to shut this down. We were very successful in that it never took place. In fact, the following year, I went to meet one of our senators' healthcare aides, and she said, you don't need to introduce yourself to me. Because of you, I had over 3,000 emails in my inbox. My email was locked. My email account was locked for several weeks. She said, you did a great job with that. The senator wasn't listening to me, but when he saw how many people were concerned about this project, he said he realized he had to listen. So we can work together, and we'll talk more about that. I would like to move the discussion onto a more timely, more relevant, more current issue, which is known as pharmacy benefit managers. And most people aren't aware of even what a pharmacy benefit manager is. And just to give you a little background, the pharmacy benefit managers are who your insurance companies hire to manage your oral prescription benefits. They started off as just claims processors back in the 80s and 90s. All they would do is process insurance claims for oral medications. Well, over time, they evolved, they coalesced, they merged to the point to where there are essentially 3 pharmacy benefit managers that manage the oral prescription benefits for nearly 80% of all Americans. That's a lot of control and influence. Well, what happens when you have this control and influence? Stay tuned, we'll talk more about that. But these pharmacy benefit managers are so lucrative from a business perspective that they are merging with the top largest insurer companies in the country. In that, one of the largest pharmacy benefit managers, CVS Caremark, recently bought one of the nation's largest insurance companies, Aetna. Well, 3 of the largest pharmacy benefit managers are owned or own some of the top 4 largest insurance companies in this country. So there's a lot of vertical integration going on. And it's because this component of healthcare has become so profitable. It's like, well, why has it become so profitable? Well, these pharmacy benefit managers, and more we're learning about this. In fact, this gets us to something that's near and dear to my heart, the price of drugs. I think the price of drugs are crazy. They're astronomical. They're very high. And it's difficult for patients to get their care because these newer medications and treatments cost so much. Well, studies are showing that when it comes to brand name drugs, we don't even talk about generics. It's a lot more complicated. Brand name drugs, probably well over 50% of the cost of any drug, whether it be oral drug or IV drug, over 50% of that is going to somebody else as a rebate. Yes, over half the cost of drugs. So if you're on a drug that costs $1,000 a month, over $500 of that is going to a rebate in somebody else's pocket, not the pharmaceutical company's pocket. So a lot of people like to complain to the pharmaceutical companies about drug prices, and I'm not letting them off the hook. But when I meet and I talk with a lot of the senior national executives in pharmaceutical companies, and they're aware of my stance that drug prices are too high and they need to get them under control and they need to do something about it. But part of the reason why the costs are so high is because of these rebates that are given out. Well, these rebates are from the drug companies, but they have to be built into the cost of the drug. And one of the nation's largest recipient of rebates are these pharmacy benefit managers and or insurance companies. Yes, the U.S. government via Medicaid and the VA healthcare system, they get some rebates. And they are a decent sized percentage of those rebates, but nowhere near as large as the rest of the rebates. In fact, some studies are showing that well over $150 billion a year in 2019 dollars was spent on rebates. And that's one of the reasons why the cost of drugs are so high. And when I talk with the senior people in pharmaceutical companies, they are somewhat traumatized after they have discussions with these pharmacy benefit managers because they have to talk with them and set up contracts before the pharmacy benefit manager will make their new medication available to the lives that they cover. And this is a typical comment I hear about that a pharmacy benefit manager would tell a pharmaceutical company. Wow, we really like that drug, your new drug. It's great, and we'd love for our patients to have access to it. But they need to know that we're working for them. So up front, we want you to give us a 10% discount off of the price so they can see we're working for them. And then after they've paid their copay, and after all the claims have been processed, on the back end, we want a 50% rebate. Otherwise, they will not even know your drug exists from us. And so these guys, they want their drugs to be available. And like I said, 3 of the largest pharmacy benefit managers control nearly 80% of the prescription benefits. If you don't let them have what they want or some version of it, your drug's not going to see a lot of patients or not even have the possibility to be used for a lot of patients. So there's definitely an issue with the rebate system going on, but also on the other end, the pharmacy benefit manager will also go after the providers. When I say the providers, the pharmacists, or in the case of cancer patients, if the cancer doctors are providing the drug, even the oncologist. they like to come back to us about, months after the transaction occurred, i.e. the prescription was given, and they'll just come back and say to the provider, either the cancer doctor or the pharmacy, and say, yeah, you owe us 10% of all this money. And it's like, why do we owe you 10%? So, well, you didn't meet quality measures. And this is exactly what was told to my practice. You didn't meet quality measures. Like, we didn't know that there were quality measures. They said, well, you're correct. There's not any oncology or cancer specific quality measures. So, we looked at the cancer patients that you're taking care of, our cancer patients that you're taking care of, and we looked at their adherence rates to blood pressure medications, diabetes medications, and cholesterol medications. And well, they were all perfect and they were adhering to their medications. So we couldn't use that data. So we looked at the entire Southwest Florida regional adherence rate to blood pressure medications, to diabetes medications, and cholesterol medications, and we applied that to you. And because the compliance rate in Southwest Florida is not very good, you've got to pay this penalty. And, my people know that if we don't pay this, what's called a DIR fee, direct and indirect remuneration fee, then we get kicked out of network. We can't take care of our patients. And trust me, if we can provide the oral medications to our patients, they will have much better patient care than if it's provided by some third-party specialty pharmacy that's nowhere near here, that knows nothing about patients or patients' care. So we do what we can on our end to try to sustain those fees. But those are just examples. Now, that's how they affect the business end of thing. That's how they affect the pricing end of thing. But in order for these pharmacy benefit managers to make more money and to steer more traffic towards certain products, they develop these formularies. And these formularies are, I guess you could say, their versions of preferred drug lists, and that drugs that they like, and some might even say, yes, that might be the appropriate indication for the drug, but are they getting higher rebates on this drug, and that's why they like it or not? We don't know. All that information is privileged and considered to be proprietary. But they have these formularies, and we're seeing perfect examples of how these formularies that they're trying to implement on cancer patients, they don't really work. You have cancer, you know that you may have other unique healthcare conditions, and it's not like there's a plethora of medications with which you can choose from, which some might consider to be your best treatment option. Why? Because different medications have different adverse side effects, and some may have an adverse side effect profile that may be detrimental to you given your unique health characteristics, or may not be better for you given your unique cancer. And so it's very difficult to say that just because I have cancer and it is cancer type X, that you should always start off with this one medication that these pharmacy benefit managers are saying you should start off with. And I can give you a perfect example. Let's tie it into patients. One of the things that we do is that we collect what's called patient PBM horror stories. And I do want you to know, if you have had any of these horror stories, as I will be talking about in a minute, please type in the little text box your name so that we can, and the best way to reach you, so that we can reach out to you at Flasco and get your horror story recorded. We do this at the Flasco level. We do it at a national level. I do it with a national organization I work with called Community Oncology Alliance. If you go to pbmabuses.org, that's P as in Paul, pbmabuses.org, you can see, unfortunately, volumes of horror stories that have resulted from these pharmacy benefit managers negatively impacting patient care. Just to give you an example, getting back to the formularies that we were talking about, we have several examples that have even happened here in Florida where a patient with a condition and other cancer and other medical conditions, for example, like bad kidney disease, should be getting, if you look according to routine formularies and what's considered to be the number one line of therapy, a medication that its number one side effect is that it can impact the kidneys. Okay, well, one of my partners saw this patient and realized, wait, this patient needs this medication. It could impact the kidneys. They have bad kidneys. Then maybe we need to start them on the second line medication first, period, and avoid this potentially more dangerous one. They sent the patient to a local cancer center of expertise, and their specialist in this cancer said, yeah, you can't have that number one, that first drug, that first medication. You need to start off with the one second on the list because it could hurt the kidneys. Well, it took the pharmacy benefit manager over 2 months to approve the medication because it was denied because it wasn't number one on their formulary So we have several examples of where they can delay access to timely care. We even have examples nationally of patients just dying while they're waiting for their medication to arrive. An unfortunate example of a patient who waited 9 weeks for a routine metastatic breast cancer medication to arrive, but the pharmacy benefit manager fought with the provider for so long, the patient gave up after 8 weeks, went into hospice. The medication showed up just after that, but the patient was too weak to even take the medication. We have other examples of where the pharmacy benefit manager, I have 2 examples in my practice, not with me, but with 2 of my partners, of where the pharmacy benefit manager actually said, no, we know this medication is front line and is the first one that's listed to be used, but we think the patient should have surgery first. And in both instances, even the surgeon and the medical oncologist said, no, surgery is contraindicated in this patient. They said, well, no, we think the patient should have surgery first. So they're making a medical decision without even seeing the patient. They're making a medical decision without a license to practice medicine. And that's one of the things they're doing to save money and to help their bottom line. These guys are businesses. They took an oath to their shareholders. They did not take an oath to patients like the doctors did. And so if you have a horror story, please type it in on the question box so that the people from Flasco can contact you, hear your horror story so we can get it documented. We need to have these documented. And part of the reason why is that we are working on trying to reform the healthcare system as far as these pharmacy benefit managers are concerned. We're working both at a state level and at a national level. To give you an idea of what we've been doing at a state level, in fact, we've been coordinating with other healthcare advocacy organizations, and we attempted to have legislation passed last year for pharmacy benefit managers. It would have held and made sure there was transparency as well as accountability, because right now there's no transparency. I was in DC a couple of years ago and was talking with some key staffers on both the Senate and the House, and they said, yeah, the pharmacy benefit managers people were up here yesterday and they were lighting their hair on fire saying, oh no, we can't be transparent. That will disclose proprietary information. We won't be able to save money. There's no way we can be transparent. Well, you know, this is healthcare. Everybody needs it. And if you have to be that transparent, then is there a reason for that? So we want reasonable transparency and we wanted accountability. And unfortunately, that bill did not pass. It did not go up for vote in the House or the Senate, but we will be working on that again for next year. And that's one of the reasons why I want to grab your attention. We will be working on that next year, and we will need your help with reaching out to your legislature, your state representative and your state senator, so that they will know they need to support this bill. Now, with that being said, to give you a little bit more of an idea of how conniving these pharmacy benefit managers can be, one of our other organizations developed a study looking at Florida alone, just to better understand how these pharmacy benefit managers worked in the Medicaid system that's run by the state. And just in one example, with a generic medicine, they saw that the pharmacy benefit manager was paying a pharmacy that they didn't have a preferred contract with. They're paying this pharmacy approximately 20 cents a pill for generic medicine the patient needs to take twice a day. And they were paying a pharmacy that they had a contract with. Now you got to keep in mind, this contract that they have with the pharmacy is not accessible to the public. Why? Because it's proprietary. Well, they were paying them $10 a pill. And when you sit down and you look at things, it would not be reasonable, given the fact this medication is taken twice a day, every day, within a year, if you assume a reasonable number of patients are on this medicine, it's a commonly used medicine, very commonly used medicine, that it wouldn't be reasonable for there to be a $30 million discrepancy going into this preferred pharmacy's pocket. So that has caused a lot of uproar in Florida. That was not able to get this legislation passed, but it was able to get the governor to hire a nationally renowned actuarial firm to do their own study to validate and verify what this other study has seen. If there's that large of a discrepancy, then if it's the taxpayers' dollars, I think the taxpayer deserves to know, why is this pharmacy getting paid so much more for pill than your average pharmacy? Okay, that stuff needs to be known. There's been a lot of reform going on at the state levels because of little tactics like this, especially in Florida, especially in Ohio and Georgia. We want Florida to be next, and so we'll be reaching out to you to advocate more next year. We're also working at a national level in DC with a couple of different bills, a couple of pieces of legislation, one so that patients could get their drug within 48 hours, and they wouldn't be waiting several weeks or even months to get their medication. Now, some of that stuff's been put on hold because of COVID, but we plan on bringing that up at the beginning of next year, because right now, with the way things are in DC, not a lot's happening at all within the next several months because of COVID, because of the elections, but we are working on it as we can. So your involvement is essential. As I told you with the example, when it comes to healthcare reform, if your elected official hears about you, the voter, and they hear that you are concerned, they will listen. And we are planning on this next year, for this next 2021 legislative session, we are planning on having a bill introduced to help reform pharmacy benefit managers. But we need to have a coordinated effort, because there might be more than one bill out there. We want to make sure that you are sponsoring the correct bill. We want to make sure that you know why. So it's a good idea, I think it would be, if you are interested and want to help verbalize your opinion as a voter to your elected officials, that you put your name and email in the question box. Let them know you want the monthly newsletter. It's a monthly patient newsletter. That's one way to stay updated. Not only will you learn about advocacy issues, but you will learn updates about all the different things that we talked about today. And just as well, you can go to the website at www.patients.flasco.org to learn more about not only advocacy information, the things that I'm talking about here today. Once again, it's to make sure there's a coordinated effort so that you know when to reach out to your elected official, you know what to talk about, you know which bill to tell them they need to support, but it's also to learn more about other things for patients, such as assistance programs, various support groups, as well as clinical trials, and yes, of course, something important and dear to me, information about advocacy. And also, we plan on notifying all the patients that have participated in these Living with Cancer series when there is a time we need to call them to action, because you can help us, the providers, make sure that you have access to care that's affordable, quality, and that people are not taking all the money that's being designated for healthcare, instead of it going to the patients, they're putting in their pocket. We got to put a stop to that. So I appreciate your attention, and please sign up for the newsletter, go to the website. Any questions, once again, please direct them in the question box. Your questions will be answered, but you all have a great evening. Thank you. God bless.